Hello, good morning everyone. Good morning everyone. Am I audible?
Yes, ma'am, you're audible.
Okay, thank you. Okay, so we have started with clinical problems in practical pharmacology. We are going to continue with that. I hope you all have your records. So if you don't have it, you can just save this video and later you can just copy down this. Now, whatever I'm projecting, so that you can copy down in your record. And the remaining, whatever whatever I'm doing, it is the discussion part. So if you have your record, please keep it ready. Okay, we shall start. So the 11th clinical problem. Mrs. Aishwarya, 30 years, rushed to see her physician with complaints of intense headache and vomiting since the past 5 hours. Her vision had dimmed and she was panicky. After ruling out systemic causes, the physician referred her to an ophthalmologist. He diagnosed her with acute congestive glaucoma and admitted her. Aggressive therapy was started. Now, this is the case. So as you can see here, the diagnosis is already given. Okay, so even if the diagnosis is not given, so with the clinical features of headache, vomiting, and decrease in the vision, you can think of a ophthalmology problem, which is probably a glaucoma. Now, usually only in case of acute congestive glaucoma, you will have the severe symptoms. Otherwise, if it is chronic glaucoma, it will be gradual decrease in the vision. Here are the questions. Mention various groups of drugs useful in this condition. So now the diagnosis is already given. It is acute congestive glaucoma. So before going into the drugs, so I'll just briefly tell you about glaucoma. So as you know, the normal intraocular pressure is less than 21 millimeter mercury. Now, whenever there is increase in the intraocular pressure of more than 21 millimeter mercury, there is damage to the optic nerve. This together you call it as glaucoma. Now, there are different types of glaucoma. We have open angle glaucoma and closed angle glaucoma. Now, in open angle glaucoma, the iridocorneal angle is normal. So here what happens is there is gradual degeneration of the trabecular meshwork. As a result, the trabecular outflow of the aqueous humor is diminished. So here, as a result, what happens is gradually the intraocular pressure increases. The second one is closed angle glaucoma. So here the anterior chamber is narrow, and as the name says, the iridocorneal angle is narrow. Now in these patients, whenever you give mydriatics, there will be precipitation of acute congestive glaucoma. So this is the case what we are discussing today. Now coming to the medications. So there are several group of drugs which are used in glaucoma. So when you're treating glaucoma, there are two approaches. One is you can decrease the production of aqueous humor, or you can increase the outflow of the aqueous humor. Now the drainage of aqueous humor is by two pathways. One is your trabecular pathway, the other one is uveoscleral outflow. So either by decreasing the production of aqueous humor or by increasing the outflow of aqueous humor, you can decrease the intraocular pressure. Now here we have the list of drugs. The first group is beta-adrenergic blockers, that is your beta blockers like timolol, betoxolol. Now these group of drugs, they mainly decrease the synthesis of aqueous humor. Then we have miotics, that is pilocarpine. So these drugs, by causing meiosis, they increase the trabecular outflow of the aqueous humor. Then we also have physostigmine in this group, but it is no longer used because of toxicity. Then we have the alpha adrenergic agonists, that is your adrenaline, and prodrug of adrenaline, that is dipivefrin. Now these drugs, they decrease the synthesis, that is the production of aqueous humor, and also they increase the outflow of aqueous humor. The next is alpha 2 agonists, that is apraclonidine and brimonidine. Are you with me?
Yes, mom.
Okay. So now we have the apraclonidine and brimonidine, which are alpha 2 agonists, which belong to the group of clonidine, but the use is different. Now these drugs, they decrease the production of aqueous humor. Next we have carbonic anhydrase inhibitors, that is acetazolamide, which is given orally, dorzolamide, which can be given topically. Now these drugs, they decrease the production of aqueous humor. Then we have the prostaglandins, that is latanoprost and travoprost. Now these prostaglandin F2 alpha analogs, now these drugs, they increase the uveoscleral outflow of the aqueous humor. So these are the group of drugs which can be used in glaucoma and their mechanism of action. Now coming to the next question, mention the drugs to be avoided in this patient. Now, whenever we ask what are the uses of miotics, you tell glaucoma. What are the uses of mydriatics, you tell glaucoma. So what you have to understand is miotics are useful in glaucoma, whereas atropine, that is the mydriatics, your passive mydriatics are absolutely contraindicated in glaucoma. So that is what you have to remember always. Now this anticholinergic drugs, that is atropine, tropicamide, these drugs, because they cause mydriasis, they block the they cause pupillary block, so the outflow of aqueous humor is decreased. So therefore they precipitate glaucoma. So similarly with imipramine and fluoxetine. Then we have levodopa, so even this can precipitate glaucoma. Then we have corticosteroids, which can precipitate glaucoma. Then your anti-epileptic, that is topiramate, it can cause cilio-choroidal effusion, which results in displacement of lens iris diaphragm. So these are the drugs which are to be avoided in patient with acute congestive glaucoma. Now the third question, what are the advantages of using topical beta blockers over miotics? Now, when we discuss about the drugs used in glaucoma, so we always think of pilocarpine or beta blockers or prostaglandin F2 alpha analogs, which are very commonly used. Now, among all these, prostaglandin F2 alpha analogs are the one which are most commonly are the one which are more effective and which have less adverse effects. But because it is slightly expensive, maybe in developing countries it may not be choice. So we are left with beta blockers and pilocarpine. Now, beta blockers, they have many advantages over pilocarpine. So as I told you, miotics, that is your pilocarpine, because it causes meiosis, there is change in the pupillary size. Whereas with the beta blocker, the mechanism is different, so they do not affect the pupillary size. Then these beta blockers, they do not cause diminution of vision, especially in patients with cataract, unlike your pilocarpine. Beta blockers, they do not induce myopia and they do not cause brow pain, which is common with pilocarpine because of the ciliary spasm. And because the pupillary size is not affected, now with beta blockers, there is no fluctuation in the intraocular pressure and they are also longer acting. So the intraocular pressure is maintained. Whereas with pilocarpine, because it is short acting and it causes meiosis, there is frequent fluctuation of intraocular pressure. Pilocarpine, it needs to be administered repeatedly because it is short acting, whereas your beta blockers like timolol, it can be given twice daily or once daily. So this is about the first clinical problem, so which is a case of acute congestive glaucoma. So whatever I have projected, you can copy down in your record. Now, in this clinical problem, the other important questions which you can expect is the drugs used in glaucoma, so you have to be thorough with that, and pilocarpine, which can be a short answer or a short note. Coming to the next clinical problem, a patient of moderate hypertension was put on chlorothiazide and hydrolyzine combination. Later, the patient started suffering from anginal pain. So the physician decided to change the drug hydrolyzine. Can you justify the physician's thinking? Now, in this case, already the diagnosis is given. So it is a case of moderate hypertension, and the patient is already on medication, that is chlorothiazide, which is a diuretic, and hydrolyzine, which is a vasodilator. Now, after starting this, patient has developed anginal pain. So therefore, the physician is thinking of changing the drug hydrolyzine. Now, why do you think the physician wants to change this hydrolyzine? What problem it is causing? Why is it precipitating angina? So to understand that, you have to understand the actions of hydrolyzine. So now you all know hydrolyzine is a vasodilator. It causes vasodilation. So there is hypotension. Now one of the adverse effects of hydrolyzine is because of hypotension, there is reflex sympathetic stimulation. So there is reflex tachycardia. So there is increase in the cardiac activity, which can precipitate angina. So that is the reason why the patient, is advised to go for a change for hydrolyzine. So the physician's decision to change the drug hydrolyzine is justified here because hydrolyzine is a potent vasodilator, predominantly arteriolar vasodilator. It can cause fall in blood pressure, which is associated with reflex increase in the sympathetic stimulation. This results in cardiac stimulation, causing tachycardia and palpitations as well. As a result, there is increase in the myocardial oxygen demand. This can lead to precipitation of anginal attack. So this is about this clinical problem. So little bit discussion on this. Now, as I've told you, this is a case of hypertension. Now, if you're not, knowing it is a case of hypertension, then how to diagnose a case of hypertension? So, whenever the blood pressure is more than 140 by 90 millimeter mercury, consistently on 2 to 3 recordings, then you can take it as hypertension. Now, when you diagnose a case of hypertension, it is important to find out whether it is essential hypertension or secondary hypertension. Now, usually, essential hypertension is where the exact cause is not known, and it is usually seen after 40 years of age, mainly because of stress, lifestyle, and increased salt intake, all that, which is very common. Then we have the secondary hypertension, which is because of the underlying cause, like pheochromocytoma, where there is an adrenal tumor. So there is increased catecholamine synthesis. So that is the cause for hypertension here. The other one is renal artery stenosis. So whenever you have a case of hypertension, you have to see whether it is essential or secondary. Because if it is secondary hypertension, until and unless you treat the cause, you cannot control the blood pressure. So if it is pheochromocytoma, you have to treat it. If it is renal artery stenosis, you have to treat it. Now, if it is essential hypertension, then we have the group of drugs available. So, you have alpha 1 blockers, we have beta blockers, calcium channel blockers, AC inhibitors, ARBs. So, there are various group of drugs which can be, used for hypertension. Now, whenever you're making a choice of antihypertensive drug, you have to consider the existing other comorbid conditions like diabetes or ischemic heart disease. Now, here in this case, you have seen they have given combination of thiazide diuretic with hydrolyzine. Now, thiazide is a diuretic. So what it does is it increases the sodium and water excretion. So the sodium content will come down. So your peripheral vascular resistance will decrease. And also it has some local vasodilatory property which contributes for its antihypertensive action. Whereas with hydrolyzine, it is a potent vasodilator, mainly arteriolar dilation. So that is a mechanism. So by releasing nitric oxide, it causes vasodilation. Now, as I have told you, whenever you have to make a choice of antihypertensive drug, you have to keep in mind the other existing diseases. So if they have underlying diabetes mellitus or ischemic heart disease, then the choice of drugs will be your AC inhibitors or ARBs. AC inhibitors like captopril, ramipril, or your angiotensin receptor blockers like losartan, telmisartan can be used. The reason is these drugs, they have some cardioprotective action. So they prevent the ventricular remodeling and they protect your heart. And at the same time, if they have diabetes, they also protect your kidney from developing diabetic nephropathy. So that is why whenever patient is having hypertension associated with any cardiac disease or diabetes, the choice will be your AC inhibitors or ARBs. Now I'll tell you about the various drug combinations which are useful and which are to be avoided in hypertension. Example, like in hypertension, you can use combination of AC inhibitors and diuretics. Now the rationale behind this is, now AC inhibitors, one of the side effect is hyperkalemia. And diuretics, like your thiazide diuretics, they increase the potassium excretion. So the adverse effect of AC inhibitor is neutralized by your diuretic. Then calcium channel blocker can be combined with diuretic. Now the reason is calcium channel blocker like amlodipine, they cause water retention. There is edema. So that is the most commonest side effect of amlodipine. It causes edema. So whereas with the diuretic, they increase the water excretion. So they neutralize the edema side effect of amlodipine. Similarly, we have various combinations which are to be avoided in hypertension, like AC inhibitors and ARBs. Now, this combination is irrational because they act by, the actions are quite similar. Okay. Now, if you combine them, the hyperkalemia side effect may be aggravated. So therefore, it needs to be avoided. So either you have to use AC inhibitor or you have to use ARBs because they have similar side effects which get added up. Or you have to avoid the combination of AC inhibitor with a potassium sparing diuretic like spironolactone because both of them cause hyperkalemia, so it will worsen. So this combination should be avoided. So like this, you have various combinations which are rational and irrational. So you have to be aware of all those. Coming to the next clinical problem. Mr. Krishnan, a psychiatric patient, was on a large dose of chlorpromazine for past 1 week. He developed rigidity, tremors, mask-like faces, a shuffling gait, and bradykinesia. So what is the diagnosis? So as you can see here, he is a psychiatric patient, so maybe he's having psychosis. He is prescribed chlorpromazine, which is a typical antipsychotic. So after 1 week, he has developed rigidity, tremors, mask-like faces, shuffling gait, bradykinesia. So as you can see these symptoms, these are symptoms of Parkinsonism. So he has developed this after taking chlorpromazine. So you all know chlorpromazine is a typical antipsychotic. One of the adverse effects of chlorpromazine is drug-induced Parkinsonism. Because of the blockade of D2 receptor in the basal ganglia, it causes Parkinsonism-like symptoms. So that is what the patient has developed here. So the mechanism of action of chlorpromazine as an antipsychotic is it blocks D1 and D2 receptor. So because of blockade of D2 receptor, the patient will develop various extrapyramidal side effects. One of it is the drug-induced Parkinsonism. So what is the diagnosis? This patient has developed drug-induced Parkinsonism. Extrapyramidal disturbances, the major dose-limiting side effects seen with antipsychotic drugs like chlorpromazine, and usually they appear between 1 to 4 weeks of starting of the therapy. What drugs are used to correct these side effects? Now, it is a case of drug-induced Parkinsonism. It is because of the blockade of D2 receptor. Now, whenever we think of treating Parkinsonism,